Unfortunately, Professor Hamdi is not able to attend today. He's unwell, as previously mentioned. So I'm his fellow. I'll be presenting his talk. I'll share some, I'm not the expert here, but I'll share some of his experience and some of what I learned from him during the past year. We want to thank also my co-fellow Khaled Abudalo, he's sitting in the back here. Dr. Mitchell Bernstein, my other fellowship mentor. And there is nothing to disclose here. So objectives, Dr. Hamdi wanted to touch base on some principles and advances in rickets, fibrous dysplasia, and OI, focusing on techniques and implants. So to summarize, just basically, metabolic bone disease can affect different parts of the bone. It could be the minerals, like the case of rickets. It could be the cells, like the case of fibrous dysplasia, or it could be the collagen, like OI. Most long bone deformities, they have shared features. They are systemic disorders. They may involve multiple bone segments or all bone segments sometimes. The structure of the bone is abnormal. The bone is brittle or pliable. So brittle basically means they can break very easily with low energy trauma, and pliable basically they can deform easily. The deformities in such cases, they're not the simple deformities we deal with. They're usually complex, multiplanar, multi-apical, multi-segmental, progressive, and has a very high recurrence rate. So the principles of management of these problems is basically medical and surgical. These problems you cannot treat alone. You need a multidisciplinary team, including people from metabolic disorders, specialists in genetics, in medicine and pediatrics, and other surgical specialists as well. The goals of treatments in such problems is to maintain, to correct the deformities, protect the bone, optimize function, and to improve the quality of life. So again, we're going to touch base on the three diseases here. So we're going to start with rickets. Rickets has a very good medical treatment, depends on the cause. There are different types of rickets. We're not going to go through them today, but medical treatment usually works well and can correct deformities without surgeries. Surgical options depends on many factors, depends on the deformities we have, the patient age, the bone itself, the diameter of the bone, the length, and many other factors. And skeletally immature, you can use growth modulation, can work here. Acute correction or gradual correction, you can use. Usually we want to protect the whole bone, so you can use like something like intramedullary nails, which works very well. Skeletally mature patients, you can use gradual correction with frames. You can use nails and other forms of treatment. So this is an example of a case, an 18-month-old kid coming with bowed leg, was diagnosed with rickets, hypophosphatemic rickets. And with follow-up, with medical treatment without any surgical intervention, you can see the deformity is improving. Another example for a Genu valgum case that was treated with a skeletally immature patient that was treated with growth modulation and had overcorrection and then rebound. In small kids, you can do acute correction with stabilization with cast and simple tools like K-wires. This is an adult patient, 20-year-old female with hypophosphatemic rickets. Without even looking at the x-rays, I think people who attended the course in the past few days, they can basically understand that this is a multifocal, probably multi-apical deformity complex that you have involving more than one segment. This is just a demonstration of the software planning and the simulated correction of the deformities. And this is one side, that's the right leg, that was corrected with deformity correction on the femur with osteotomies and nail. You have to understand preoperative planning is very critical here. So this is a small diameter nail from orthopediatrics, for example. And the tibia deformity was corrected gradually with a frame, and you see the correction, and this is basically the clinical picture is when the patient was brought back for the other side. You can see the leg got straight and gained length even. So take-home message for rickets: medical treatment is important, and surgical correction, you need very careful planning and understanding of the patient and your implants and the surgical options. Fibrous dysplasia, Dr. Hamdi wanted to touch base on two principles: bone grafts and correction of proximal femur Shepherd's crook deformity. So bone grafts, don't use them in fibrous dysplasia. That's the message you need to learn. Whatever kind of bone graft you use, autograft, allograft, cortical or cancellous, they will not work. They will resorb with time. This is an example of a case that was treated with a nail, fibrous dysplasia of the femoral shaft. And you can see that basically the lesion still persists, basically. The proximal femur deformity technique that Dr. Hamdi wanted to basically highlight is basically when you have a severe deformity with a neck shaft angle less than 90 degrees, usually it's not feasible to treat in a single stage with a nail. So usually you stage them. First stage, you correct the coxavara, you plate, then you come back later on and protect the whole bone with a nail. And just to remind you that these kind of conditions can be very complex and very hard to treat. This is an example of a syndromic fibrous dysplasia and McCune-Albright syndrome. And again, we can basically, if you want to know more about the surgical management of such disease, there are good series with long-term experience. One of them is basically from Sheffield, from Mr. Fernandez group here. So take-home message for fibrous dysplasia: stabilize the fractures and deformities with the intramedullary nail, protect the whole bone, avoid plates because of weak purchase. Bleeding, you should always, in metabolic bone disease, bleeding is an issue. Delayed healing, you should be patient with your follow-ups. Avoid bone grafts, and don't forget that the lesions persist. And eventually, you cannot rely on bone grafts, and you need metals to replace the mechanics of the bone. And in this case, in fibrous dysplasia, usually medical treatment is only for symptomatic control. OI, Osteogenesis Imperfecta, we're gonna go through some basics of deformity analysis and surgical implants. We have a good experience at the Shriners Hospital in Canada. They're actually a very high referral center of OI, and they have a good multidisciplinary team over there. So two main problems with these patients. There are very, very complex and severe deformities, and they are difficult to analyze. And just an example like here in this case. And the bone can be very thin, and sometimes you don't have even a canal like this. This clinical picture is basically a tibia intraoperatively, and you can't see any intramedullary canal. And these patients, you don't want to put a plate on them; they're going to break. You don't want to put an external fixator or a frame; they're going to break through the pins. So it has to be something intramedullary. Again, reminding you of the complex deformities, multiplanar and multi-apical. So nowadays we use 3D imaging and 3D printing also. This helps a lot in understanding the deformity and planning your osteotomies. So surgical treatment, again, protect the whole bone, do not plate. I'll show you an example of what you should not do. This is a patient with OI who presented with a femur fracture, was treated with a spine surgeon on call with elastic nails and a plate, and got some healing, then broke at the tip of the plate, then was revised with a telescopic rod, fascial Dover rod, FD rod. Again, many surgical options. You need to understand your patient, you understand your implants. If you want to treat these patients, you should be comfortable working with different implants and different surgical tools. Understand when to use each. Patient features like skeletally mature, skeletally immature, diameter of the bone, length of the bone, all of these are important factors you should consider when you choose your implant. I'm going to just show you some examples of the implants we usually use in OI. For FD rod, it comes in different sizes and different lengths. So basically, this is an example of OI. treated with fascial Dover rod in the femur and the tibia with osteotomies, deformity correction, and telescopic rod. And you can see the same patient, for example, if you look at the femur, you see how the components of the nail, there are two parts, male and female components. You can see them telescoping over each other. And you can see on the left femur here, it's basically losing the part of the distally, the nail is losing its purchase in the femur. And this is a common complication you can see. And with follow-up, you can see it's basically the kid is overgrowing the rod, and it's not telescoping, and you have to revise. Another implant, which is not well described in the literature, we're working on a publication very soon, the slim nail. It's an implant that has a proximal purchase, a solid rod with a proximal purchase, and there is locking option also. Comes into many sizes from like diameter of 2.0 until 6.4, and many length also. So this is an example of an OI kid, again, with very narrow bone and the tibia. So the femur was fixed with the FD rods, and the tibias were fixed with the slim nail 2.0. It's like putting a toothpick basically in the bone. Another one, another OI case, non-ambulatory, was all segments were rodded with a slim nail. And that's another one. They can last for 5 years if the patient is non-ambulatory, but if the patient is still skeletally immature and growing, these will be revised very quickly, like within a year or two maximum, because the patient will overgrow the rod, and will probably break at the distal tip. This is another example of a patient treated with retrograde femur slim nail with some plate augmentation temporarily for more rotatory control, so to add more like biomechanical stability here for rotation. And this, usually we remove them later on. Another example, humerus non-union, treated with retrograde slim nail and plate augmentation for rotation. And once osteotomy or fracture is healed, we remove the plate. Different examples also of slim rod. If you see from the left side, it's on the tibia with proximal interlock. The second picture is basically with a plate augmentation. The third picture is subtrochanteric fracture with the plate augmentation. Fourth picture is basically a fibula, painful non-union that was treated with a slim rod. And then the last picture is an ulna, which was treated with also a slim nail. Then there is another new implant, which is the gap nail. This is like a solid nail, usually used for older children. This is an example of a case with a fracture over an FD rod that was treated with a gap nail. And just take-home messages for OI. Medical treatment is very critical. Bisphosphonate, you need your multidisciplinary team also. Preoperative planning is very important. In the OR, you need your reps to be available also to help your nurses and your team. Avoid external fixation and plates again, they will break. Telescopic rods is very important for skeletally immature, and more rigid rods for skeletally mature. You need to preserve the bone as much as possible. You don't want to ream and put a big implant, or the bone will be resorbed. Thank you.